were a target also, the DEA. And the DEA came in, and I appreciate their input, but they also said if we don't fix it, quote, they will. Their idea of fixing it was they literally said, we'll arrest 5 doctors in the state for overprescribing, and that's how they would shut it down. So we also stepped up then like, okay, it'd be a lot easier for us to handle it because I don't want to see doctors getting arrested, particularly some who aren't, malignantly doing something wrong. And we never wanted to turn this into a witch hunt.
A doctor in Southwest Arkansas is back prescribing medicine tonight after reaching a deal with the state medical board.
THV 11's Rolly Hoyt says Dr. Lonnie Jo Parker has a troubling background and has been on drug enforcement officials' radar for months.
The state drug director is disappointed.
We have to start stepping up and making the difference in it.
Disappointment in the voice of state drug director Kirk Lane. Dr. Lonnie Joseph Parker expressed contrition to the state medical board after losing his right to prescribe medicine earlier this year.
One of the comments was that you treat patients with addiction.
The Texarkana doctor who just got his prescribing privileges back Friday is arrested today on federal pill mill charges.
Many physicians treating patients who suffer from pain and addiction may wonder what criteria the DEA believes to be indicative of a pill mill. But all doctors should be worried. Any physician treating ADD or depression with controlled medications is now at risk of being targeted also, as are any doctors reaching out to patients through telemedicine. In truth, any doctor prescribing any controlled medication to any patient for any purpose, or any doctor being innovative, needs to know that their liberty is at risk. The DEA is using false metrics to target you, and for the longest time, medical clinics have had to guess at what criteria was being used to make these claims. We filed a motion 404B, also called a Bill of Particulars, where the government is ordered to lay out its claims. The following is from the government's response to our motion. The government claimed in their response that pill mills have been found to have common characteristics, including some or all of the following. Pill mills are cash only and do not accept medical insurance. Despite the government saying this publicly and in sworn documents, they knew, should have known, or were willfully blind that this was not true of our clinic. Our clinic did not only take cash, we took many insurances. One of the patients charged in the indictment had insurance that we accepted on the day of treatment in the indictment. This was clear in the medical record, and the government had those records when they let government witnesses commit perjury on the stand. This is a crime, but since there is no effective oversight of federal law enforcement, they get away with it. If someone had insurance we did not take, they could pay cash. Many doctors choose to only accept cash, so they don't have to employ the staff required for billing. More than half of psychiatrists are cash only. In the past, many addiction specialists were cash only because insurance would pay little or nothing for this treatment. However, cash is harder for the government to trace, and while it is absolutely not illegal for a physician to be paid in cash, the government will absolutely target you for it and use it to imply to the jury that you're shady. This criterion did not apply to our practice. The next criterion listed by the government is that pill mills provide no variation in treatment. They argue that each patient is prescribed the same or substantially similar narcotics in the same or similar quantities. A possible example of this would be a clinic that this exact prosecutor shut down in Little Rock, Arkansas, where almost every patient was on 4 10 milligram hydrocodone and 3 2 milligram Xanax a day. That was not even close to the case with our clinic. Not a single patient in the indictment was on the same type, frequency, and dose of controlled medications, and the government knew this. Every one of the patients in the indictment was on very different medication regimens. So why would they lie about this? Because it's effective. Just like throwing out large numbers, it destroys the doctor's credibility to the public from which the jury pool will be drawn, and it makes colleagues reluctant to speak out for you because, since they recognize the lies, they know that they can be targeted just as easily by the same government. Using lies to play on emotions is how federal prosecutions run these days. It's like catching a kid engaging in street art, making fun of a president, let's say, and then calling that kid a terrorist. He is, after all, breaking the law and arguably destroying public property for a political purpose, the very definition of terrorism. When he goes to trial, the jury will think of real terrorist acts where people die and they'll be angry. The only one they can take their anger out on is the defendant, so their rational brains shut down and they seek vengeance instead of justice, feeling like a few years in prison is less than the life sentence that terrorists deserve. And doctors treating addiction have it really hard. By definition, they are almost always treating criminals, since it's a crime to use illicit drugs in America. Also, it wouldn't be true addiction if they could control their behavior, so these patients won't follow the rules, sometimes selling their prescribed medications to get high or testing positive for street drugs. Finally, addiction treatment at a Suboxone clinic will follow certain protocols, since almost everyone is started on the same type, dose, and frequency of medication, and it's adjusted as needed. Establishing protocols and procedures for patient treatment is a recognized and usually smart way to get things going. This can help clinic providers and staff know where to begin and be able to recognize if something is off base. An addiction clinic, for instance, might decide that all patients would be started on Subutex 4 milligrams twice a day and adjusted in 1 week as needed up or down, and perhaps changed to Suboxone if well tolerated. This would be reasonable, but according to Dr. DEA, it would also be evidence of criminal practice, a pill mill, and addiction doctors, like Dr. Thomas Reach, have been prosecuted under this false rubric. Next, the DEA says that a pill mill will prescribe a trinity of drugs, including a narcotic, benzodiazepine or depressant, combined with a non-controlled substance such as an antibiotic or muscle relaxant. When it comes to medication combinations, the DEA, with its lack of any extensive knowledge of medicine, has somehow determined that people with chronic pain should not also be afflicted by anxiety, muscle spasms, or even apparently an infection. The actual holy trinity of drug use was given that name by drug users, and it was a combination of oxycodone, carisoprodol, and alprazolam. The trade names of the last two are Soma and Xanax. A breakdown product of Soma enhances the activity of oxycodone. That is why very few doctors still prescribe this combination, though some patients who have been on these for decades will still come in as legacy patients. And study after study has shown that stopping a controlled medication when a patient is stable puts that patient at a high risk of death over the next several years, rather than just continuing it. This is also something called rational polypharmacy. Side effects relate to a total dose given, and using a low dose of two medications that amplify each other, like Soma and oxycodone, can have a therapeutic effect at a much lower dose of either one, reducing the risk of side effects. Medicine is complicated, and when the DEA demands that doctors defer to some agent's uneducated opinion on what should be done, patients suffer. Next, they say a pill mill will prescribe specific narcotics as requested by patients. If someone comes in with a wad of cash and says, "I want some oxys," and a doctor whips out a pad and says, "How much do you want? They're $30 each," you've got a crime. If, on the other hand, a patient under treatment for severe chronic pain for years comes in to be evaluated, a doctor would be negligent not to listen to them. Why would you guess at what worked best when the patient is right there? The DEA most often works with a criminal element that is always lying, and believing anything said is seen as a sign of weakness. That is not the case in the medical field. A doctor listening to what a patient has to say and taking it into consideration is not a crime. It is how medicine is supposed to be. The doctor-patient relationship is a bond of trust and mutual respect. Without it, no true healing will take place. Asking for a specific medication that you know works well is not automatically drug-seeking behavior, at least not to doctors, but it seems to be to the DEA. They also say pill mills provide little or no medical evaluation. This charge also shows a lack of fundamental medical knowledge on behalf of the DEA. The purpose of a physical examination is to tell the doctor what they need to know to treat the patient. The longer a doctor practices, the more focused and shorter the exam usually gets, especially for primary care and ER doctors. Watching the patient walk in, sit, and start to speak gives an experienced physician a wealth of information. Now a pain specialist establishing a diagnosis will do an incredibly detailed physical examination, worthy of a physical medicine rehabilitation doctor and neurologist working together. These are very helpful for the primary care doctor treating that patient. But what the PCP will not do is try to replicate that examination on every visit, or indeed any visit. If a patient comes in from an orthopedist with a diagnosis of a fractured arm, we don't take that limb from the cast or splint or sling and move it all around to double check everything, just in case the ortho was stupid. We respect and trust the opinions of our colleagues and perform examinations sufficient to determine a diagnosis. Next, the government argues that pill mills possess no medical equipment or equipment that is not operational. I'm not sure what to make of this. Almost every physician prosecuted that I could find had working equipment. If something breaks, don't keep it in the office, I guess. Here is some of the equipment we had on hand in my clinic, and it was all working on the day they kicked the door in. Then they complain about a doctor seeing too many patients per day. This goes back to the very first physician prosecution under the Controlled Substances Act. The act was written to apply to people not registered to dispense narcotic medications. But a doctor named Thomas Moore was accused of prescribing methadone without any physical examination or instructions for use, charging by the quantity of methadone prescribed instead of for medical services performed, and for writing over 100 prescriptions a day. My clinic charged the same service fee for people on blood pressure or diabetes medication as we did for those on narcotics. This alone should obviate any charge of being a pill mill. How can you possibly be acting no different than a drug dealer if you don't charge for the drugs? Now, regarding number of patients seen. Some medical boards have said that a reasonable limit is 640 patients per month. They came to that figure assuming that a good doctor would see one patient every 15 minutes, so 4 per hour, 8 hours a day, 5 days a week, 4 weeks a month. That seems reasonable at first glance, but what if you have a nurse practitioner or a physician assistant or a counselor? These people might see the patient and provide critical care at a second look, while the doctor closely reviews the record, reevaluating the need for controlled medications, and then might see the patient for 5 minutes every 90 days. This is what most specialists and focused medical care providers do now, and that puts you at 960 patients per month, almost 1,000. Clearly outside the usual practice of medicine by the DEA's definition, but not by any reasonable measure. And off you go to the big house. Now, I saw 12 to 15 patients a day. My nurse practitioner handling non-narcotic medication problems and follow-ups could see 15 to 20, and our counselor could do another 12 to 15. That would put our clinic at about 50 patients per day, so 1,000 a month. Perfectly reasonable if they had bothered to check, but they don't. Remember, with all these factors, the government is not looking for the truth and will indeed do their best to hide it. They are looking for an excuse to prosecute and convict. It is not an investigation. Your guilt has been predetermined, and innocence is not an option. That makes it an inquisition. The DEA also claimed that pill mills make no recommendation to patients for alternative therapy or x-rays and physical therapy, which my clinic did for almost every patient. And it's there in the records, and they could see it and they knew it. The DEA also complains if a doctor directs patients to fill prescriptions at certain pharmacies, considering this signs of collusion between the doctor and the pharmacist. My clinic did not do this, but the State Pain Review Board criticized me for not doing so. So we have state regulators demanding that you do something the DEA will use as criteria to convict you at trial. That is why medicine should be left to the states. You can comply with one or the other, but not both at the same time. It's impossible. I'm happy to do it either way, but I can't do it both ways at once. The next criterion is when patients travel long distances for treatment or travel in groups to the clinic. They often list 45 miles as a long distance. First, there are no towns of equivalent size within an hour and a half of Texarkana. Most people coming to Texarkana for medical care are going to have to drive. That being said, about 90% of our patients lived within 30 miles of our clinic, so we did not meet even their false criteria. And traveling in groups is common, as family members or other patients will try to save on gas and help sicker people not have to drive. Finally, as doctors treating pain quit or get shut down, patients must travel further to find one still willing to treat them. That makes this criterion the gift that keeps on giving for the DEA, as they are creating the problem that they prosecute you for. Just a couple more and we're done. Employing armed security guards. Again, this is arbitrary and not a crime. The local doctor that complained to the DEA that I would be certifying patients for medical cannabis actually had an off-duty police officer for an armed guard. I did not. I understand that there are neighborhoods where not having an armed guard is inviting disaster. And I used to be a Marine. I know all about guns, and I have no problem with a law-abiding citizen having the means to protect themselves. And I'm very aware of the several doctors who have been killed by angry patients for not treating pain. And I think it's perfectly reasonable for doctors to worry about this and protect themselves in accordance with the Second Amendment and relevant state laws. The last one, seeing the majority of patients without an appointment. Patients may love this, but apparently the DEA does not. I also think it is not practical for chronic pain patients, though exceptions must be made for cancer or unexpected events. In my clinic, we always got prior medical records and reviewed them before I would approve a patient for an initial appointment. If I didn't find that the records justified the treatment, I would not schedule them for an appointment. This is what happened to a DEA agent that tried to infiltrate my clinic. He came in to be seen and was told that he had to have an appointment. He left and called to make an appointment and was told we would need his prior records. He signed the appropriate forms and got the records. I reviewed them and did not feel they justified controlled medication therapy. There was no imaging to document his back problem, and I denied him an appointment. The DEA then falsified an MRI record from another patient and doctor and sent it to me with a report. The MRI showed structural damage to the lumbar spine, and I gave him an appointment. At the appointment, during the physical examination, I watched the patient walk smoothly into the room, sit down rapidly, and turn at the waist to talk to me. A person with severe back pain will usually walk carefully into the room, ease themselves down into a chair, and try very hard not to rotate the spine. They will also often lean back very slowly to avoid setting off spasms. I went ahead and did an exam, listening to the heart and lungs, palpating his back muscles and percussing the vertebra, and doing range of motion tests. Then I told him that I did not feel the exam warranted the opiate he claimed to have been on, and that I would not prescribe any to him. But this was not enough to prove my good intentions to the DEA. Like I said, innocence is not an option, and they prosecuted me anyway, allowing a witness to tell a grand jury that I didn't do physical exams after their own agent had received one on his visit. That is how far they will go to win their conviction. It's not about justice to them. It's about convincing the public that they are doing something effective. And I and my patients are just casualties of this war.